Greetings, everyone. You are in the Cancer Immunotherapy Breast Cancer session of the Focused Ultrasound Symposium. We're excited to have you. We have speakers for our 6 sessions that hopefully you had a chance to see. We'll introduce each speaker individually in the order that they presented and invite questions. We have some questions already in the chat. You can send others through the chat. So our first was Parwathi Chandran from the NIH, whose talk was on immune cell modulation of pulsed focused ultrasound in murine melanoma and breast cancer models. Question through the chat, Dr. Chandran, do you have a hypothesis to explain why some tumor lines revert back to a cold phenotype after partial FUS while others do not?
Yeah, so we believe that the tumor heterogeneity, melanoma and breast cancer being like 2 tumors of different cell origin, that could be a reason PFAS, pulse focus ultrasound, can immunomodulate the tumor microenvironment, but then in different ways. So in the case of melanoma, we were seeing more of a cold to hot tumor microenvironment, the shift from the hot a shift from the cold to a hot microenvironment by day 5. And in the case of 41, it was it was on a different day, but then we did see that difference. So it's apparently the difference between the tumor types, basically.
Thank you. Very good. And then I was curious in general too. You're to be congratulated, I think, for a systematic assessment of changes in the tumor microenvironment with partial focused ultrasound, and fascinating to see all those. However, many of the gene pathways that you note as being changed are not ones we classically associate with immune activation. Can you comment on their implications?
Yeah, again, great question, but then no clear answer, to be honest, because we've been we are still in the process of evaluating all the mechanisms, and from the initial or the preliminary experiments, what we again consider is the innate differences between the tumor landscapes, the immune landscapes between the tumors. So in the case in B16, we did see upregulation of immune responses, and in the case of 41, we did see the anti-tumor effect as the downregulation of cell proliferation and tumorigenic processes so this was we do have more of the mechanistic studies going on, but then yeah.
Okay, very good. Thank you.
Thank you.
All right, now we're going to move through each presentation, and if we have time at the end, we can come back to other talks. Thank you.
Thank you,
Dr. Chandran. The next was number 3, Gadi Cohen, temporal immune changes of murine breast and melanoma tumor microenvironments following pulse focus ultrasound, also from the NIH. And there was, I had a question. In evaluation of Ki67 expression in the tumors after partial FUS, it wasn't clear to me whether this was change in the Ki67 expression by the tumor cells or by immune cells. I couldn't tell that from the histology. Can you comment on that?
Yeah, well, that's a good question. It's hard to say. We did do immunohistochemistry of CD4 and CD8, like the T cells. And then it wasn't that, it was kind of scattered. So I would say it's from the tumor cells, from a very rough estimation, that it kind of want to compensate on what happened, it got treated by pulse focus ultrasound, and as a way to compensate and to grow, or this is what it did.
All right. Thank you. Are there other questions?
Yeah, I might ask a question. We've seen when we've looked at both of these lines using MR focused ultrasound, and we often will see differences in the mechanical properties of the tumor that cause the tumor to quickly be translated by radiation forces, so that the tumor can, when you pulse it with ultrasound, it can move out of the focal zone and move back very rapidly. So we see differences in response or differences in the delivered thermal or mechanical properties as a function of tumor type. Are you concerned about that maybe the 4T1 or B16 could be slightly different in how much they're being heated or how much mechanical energy they're receiving?
I would say not concerned, but definitely it is different. We cannot point out exactly why. And it can be also it can be a genetic function, of course, but also kind of the structure of the cell itself. It has more kind of actin fibers, or it's more durable. It will probably be affected more by the pulse focus ultrasound. But of course, that is an option that is very interesting, and we would definitely look into it.
Thank you.
Thank you. There's one other question in the chat to you. It says, you mentioned that 4T1 suppress genes that will result in an immunosuppressive environment. Were there any particular genes that stood out in this regard? I'm curious as to whether they were more associated with the 4T1 tumor microenvironment itself or particular immune cell types like MDSCs. Similar questions for B16. And this could prompt a long answer, but if you could do something brief, that'd be great.
I'll be brief. Yeah, we just pointed out 4 of the main pathways, the main genes that we discovered. One of them is the mesenchymal to endothelial cell transfer, and which is definitely a gene that is associated with drug, that it can reject the drug. It can kind of, yeah.
All right, super, thank you. Well done. The next is Dr. Patrick Dillon from the University of Virginia, IMM5, PD-1 inhibition to modulate response to FUS in metastatic breast cancer. Patrick, there's a question on the chat. What factor do you think most strongly influenced patient response in this trial? Previous treatment, receptor status, or other?
So,
Patrick,
thank you. Yeah. So I think that's a question that I can't answer definitively yet because the trial is actually not complete. So I'm only showing some of the preliminary immunologic data at this point. So a speculative answer to the question only is that I speculate that some of the patients who've had prior limited amounts of prior treatment would probably be more likely to show immunologic response if there's not as much immunologic exhaustion from heavy prior treatment. I might also speculate that the younger patients and also the patients with triple negative disease will be the ones who will end up having the best immunologic responses, but that's all speculative because the trial is too small and it's not done yet.
Yeah. All right. Thanks, Patrick. Yeah, and I have a question. The changes that you noticed in immune cell infiltrates appear to be less consistent or dramatic than changes in RNA-seq data. What do you think might explain that? And I related, I guess, to that is I was surprised that a lot of the changes that are seen are very similar for the ablated and periablated regions, and wondered if you have thoughts about that as well.
Yeah, so maybe I'll start with the second part of that. My hypothesis had been that we would see really dramatic differences in the immune change of this microenvironment right in the truly ablated area versus in that periablated area, with the idea that in that periablated area that we wouldn't have total tumor necrosis, that there would actually be some more controlled apoptosis and antigenic presentation in those areas. So I'm a little bit confused by that data so far. Again, I'm not showing you the whole entire picture because we haven't finished immunohistochemistry on that yet. But it may be that we're having a hard time really accurately differentiating the the zone is probably a slow transition. So there may be some challenges just spatially sorting that out. And it may be that there really truly are not major differences. So we need to do a little bit more testing to fully hash out this ablated versus peri-ablated area. Does that answer the question fairly well?
That does. Thank you. Great. There was one other question for you, but I think partly due to time, and I think I also know the answer. He's asking if there are any trends in response in the TILs comparing the different delivery schemes, the timing, PD-1 and fuzz, but you don't have that broken down yet. Is that right?
That's correct. I don't have that information to share just yet. That's, of course, one of our number one primary outcomes for the study, and we'll be presenting that as soon as we finish up. We've only got a couple more patients to wrap up the study, so hopefully next year at this time we'll be able to answer that more definitively. Very good. Thank you. The next talk was by Clifford Cho, IMM9, and just double checking if he's on here. Dr. Cho, are you on, or is Amy on representing you? Okay, we may not. So why don't we skip over, and if either of them is able to join, then we'll move forward with them. Let's just go ahead with David Gertz, IMM10. Ultrasound stimulated microbubbles enhance the potency and durability of anti-PD-L1 checkpoint blockade therapy in an orthotopic breast tumor model from Sunnybrook University and University of Toronto. There was a question in the chat during the presentation earlier that said, Dr. Gertz, thank you for sharing the interesting project. You state that the vascular disruption enhances the effects of chemotherapy and immunotherapy. However, others have mentioned that lower oxygen levels from abnormal vasculature in tumors is detrimental to maximizing radiation effects. Why would lower oxygen levels enhance your immunotherapy but suppress the effects from radiation therapy?
Yeah, so that's a good question. And I think one perspective on that would be to think about vascular disrupting agents, which were prevalent in the 10, 20 years ago. So for example, basically they induced somewhat similar vascular shutdown that occurred primarily within the central regions of the tumor. And when combined with the chemotherapy, I think the prevailing hypothesis was that the chemotherapy would then basically act on the rim of the tumor, which was more robust in terms of the vasculature, resisting the vascular collapse. And so I think there's an element of spatial effect there. And so that's reflected also in our necrosis data, which showed the central portions of the tumor were dead, necrotic, whereas the peripheral regions were less so. I don't know if that gets at that question. So I think the analog with immunotherapy might be that there's a spatial component also involved.
Very good. Thank you. Yeah, it's interesting to think it through. There's another question for you in the chat now. It says, what are potential mechanisms of action of the FUS microbubble treatment that will potentiate the response to chemotherapy plus anti-PD-1? And that may relate a bit to what you've already answered, but you may want to elaborate more.
Yeah, that's good. I think, the initial part of my answer, I guess, would be the spatial component to it. So we did a previous study in subcutaneous CT26 colorectal, and in that we did flow cytometry for different T-cell populations, and we didn't really see a significant increase within the tumor or alteration in the T-cells, except a modest increase in the T helper cells at the 7-day point, but that was a little bit surprising to us. In this context, the tumors were very necrotic, and we actually weren't able to recover enough cells to do flow cytometry. So we're currently doing abscopal experiments, I guess, looking at all the tumors. And so I think the subset of our study that looked at athymic mice, and we did not see a response in those, would suggest that there is a T-cell dependent mechanism, or at least that's a possibility. And so we're and we also, not shown there, do see a significant abscopal effect in a subset of tumors where we get a primary tumor response. So presumably there is a T-cell element to it, but we're in the process of looking at more detailed mechanistic things in terms of flow cytometry and T-cell populations.
Great. Yeah, thank you for all that. Let me go ahead, and I think I'll ask Natasha questions, and then we may have a little time left. We can go back and ask other folks. Natasha Shavani is from the University of Virginia, but now at Stanford. And her talk, IMM16, is a combination of thermally ablative focused ultrasound with gemcitabine, controls breast cancer via adaptive immunity. There's a question from one of the listeners. Depletion of CD4 and CD8 and CD4 T cells seem to impact loss of tumor growth control starting only roughly 2 weeks post-treatment. What's happening during the first 2 weeks of response?
So I guess I should clarify that so maybe I should ask for clarification on the question. Is it asking about what happens during the first 2 weeks post-inoculation or first 2 weeks following FUS plus GEM intervention?
It just says first 2 weeks of the response.
Okay, so maybe I can offer the clarification I was planning to. One thing I should know is that, we started our interventions 14 days post initial tumor implantation. So that in part might speak to what was happening during the first 2 weeks as there was no intervention. And in terms of what we're observing later, I think, some of it could be a function of how we sequenced our depletions relative to FUS plus GEM interventions. Again, our sequence was to start with an initial dose of thermally ablative FUS concomitant with gemcitabine, and then we followed up with 2 doses of GEM thereafter that were spaced 1 week apart. So it really, this result might be underpinned simply by when we're actually kickstarting a T cell response and then subsequently sustaining it with those initial doses of GEM. But I think in order to get at this particular question, we'd probably have to consider other sequences of CD8 and CD4 T cell depletion down the road.
Great. Thank you. I had a question as well. You added the gemcitabine in part to try to deplete myeloid-derived suppressor cells, and I wondered whether you have data on whether you do deplete myeloid-derived suppressor cells with that, and also whether you see enhancement of tumor-reactive T cells in the tumors.
Following GEM?
Yeah.
Specifically. Yeah, our paradigm was actually based on work that was published by Harry Baer's group at VCU, where they used essentially the same dose, same sequence of gemcitabine in the 4T1 model, and were able to sort of definitively show that there is transient inhibition of MDSCs, as well as stimulation of a CD8, and I would say functional CD8 response at that. So some aspects of our study did recapitulate that. In my presentation, I actually didn't show any of really a wealth of flow cytometry data that we've collected that speaks to this effect. But effectively, in the circulation, for instance, we saw that there was a sustained increase of not only CD8 positive cells, but antigen experienced or CD44 positive cells in the GEM recipient groups. But of course, this trended more strongly when those mice also received FUS. To your point about MDSCs, we've published this work recently in the Journal for Immunotherapy of Cancer. So the data that would show that we can transiently knock down myeloid cells, and more specifically MDSCs, is sort of embedded within that paper. But yes, we were able to observe that.
Great. Thank you. So we've got just under 2 minutes left. There are a couple of other questions on the chat that we can go back to folks we've already had speak. And unfortunately, Dr. Cho does not seem to be here. So I'm sorry he's not able to address questions for his good talk as well. So Dr. Chandran, it's a question about, does the upregulation of cytotoxic T cells, F480 cells, and M1 cells in the spleen and lymph nodes on day 1 after partial FUS inform the transformation to a hot tumor on day 3? Does this imply an innate response?
Yes, we believe that it's a strong evidence for an immune response, an innate immune response. So we have also found that both the arms of immunity, both innate and the adaptive arms, have been engaged in this anti-tumor effect, where we saw the tumor volume reduction. So specifically in the case of P16, we believe that that pattern was evidence for an innate response. Yes, thank you.
Thank you. And then Dr. Gertz has another question. I'm not sure I understand some of the abbreviations, but did you happen to look at response to PAC or anti-PD-L1 monotherapy and or single agent combined with FUS plus microbubbles? We only have about 20 seconds left, but do your best.
Our focus is mainly on the combinatorial aspect, and the reason for that was that we're essentially doing an analog to clinical trials that are ongoing for triple-negative breast cancer with anti-PD-L1 and paclitaxel.
All right. Thank you very much. Thanks, everyone. I think we're going to end here in a moment. Thanks.